Assalamu alaikum. Good afternoon. Welcome to our scientific session. I would like to introduce myself. I'm Dr. Nusrat Shuri, Assistant Professor Surgery, Noakhali Medical College. You know that doctors have three particular duties. First, to treat patients. Second, to teach upcoming students and doctors, and also do some research works. So, as a part of our duty, we do research works simultaneously while we do patient treatment and care. Today, we are going to present two cases, two resolutions. One will be presented by our honorary medical officer, and the other will be presented by you. I hope you will get encouragement about the topics. You know that as personally I'm a female surgeon, so I have to deal with so many cases of breast diseases. So I gather knowledge and data about breast diseases, and that's how I have prepared these presentations. I have studied about various diseases related to breast cases. First topic will be presented by Dr. Tum Sarwar. Please, Dr. Tum Sarwar. Assalamu alaikum. As you know that we have to treat mastitis patients, so we, because of the background that many antibacterial products have lost its efficiency due to resistance, we have to choose better weapon for combating mastitis. And because if we cannot address mastitis properly, it can turn into abscess formation, which is very suffering for patient and which requires surgery. We have learned about the methicillin-resistant Staphylococcus aureus, which is very virulent organism, and resistance against these bacteria limits us to choose a proper antibiotic. In our textbooks, we have learned about a number of antibacterial products which includes vancomycin, teicoplanin, linezolid, etc. So, in our Bangladeshi perspective, not all antibiotics are available. Only linezolid was available, which was tried by us, and but it has some limitations and complications also. Vancomycin is available, oral or IV form. Oral, not produced. Introduced. Teicoplanin, vancomycin, all are available globally, but not in Bangladesh. Still now. So, in case of linezolid, its dosage, its side effects and complication includes oral candidiasis and upper GI upsets. So, and we have to add antifungal product to combat this, and other vitamins to combat this. On the better option, I found that the linezolid group belongs to Tedizolid belongs to linezolid group, and it has some advantages like its dose is minimum 200 milligram per day, duration is 6 days course, and I wanted to know whether it works or not among my patients, and its only questionable thing was the patient, our patient are low socioeconomic condition that cannot bear the cost of the antibiotic. It cost one tablet 500 taka, which he or she thinks is a burden. But at the end of the course, it's only 3,000 taka. And if we have the benefit that we can avoid the surgery, it can save 30,000 taka. That's why we think that a proper antibiotic should be chosen. So I never studied about any antibiotic or any drug because I'm a surgeon. I always try to research on my operations. But I thought that why not I study the response of an antibiotic which I have to treat my patient. And this was maybe in Bangladesh first time I did it, and it was published in a overseas journal, and it's like a reference in Bangladesh. So, efficacy of Tedizolid phosphate in treating mastitis, a clinical outcome. Mastitis is an inflammatory condition of the breast tissue, predominantly affect lactating women. Though it can also occur in non-lactating individual. It presents clinically with symptoms such as breast pain, swelling, redness, systemic manifestations like fever. Condition is often associated with bacterial infection by Staphylococcus aureus and can lead to abscess formation if not promptly and adequately treated. Mastitis is not only a source of considerable discomfort but also poses a risk for more severe complications if left untreated, including chronic infection, abscess formation, and in rare cases, sepsis. The management of mastitis is typically involved in combination of antibiotic therapy through supportive care and in some cases surgical intervention. Historically, penicillinase resistant penicillins such as flucloxacillin have been mainstay of treatment due to their effectiveness against common causative organisms. However, the increasing prevalence of antibiotic resistance bacteria such as methicillin resistant Staphylococcus aureus poses significant challenges to traditional treatment approaches. That has necessitated the exploration of alternative antimicrobial agents that are both effective and have favorable safety profile. Tedizolid phosphate, a second generation of zolpidem, has emerged as a promising alternative in the treatment of acute bacterial skin and skin structure infection, including those caused by MRS. It has demonstrated potent activity against the broad spectrum of gram-positive pathogens, including those resistant to other antibiotic cases. Tedizolid's once daily dosing is short treatment duration and the relatively low incidence of adverse effect make it attractive option for the management of complicated infections like mastitis. Unlike other antibiotic, tedizolid inhibits bacterial protein synthesis by binding to 50S ribosomal subunit, a mechanism that limits cross-resistance with other antibiotics classes and enhances its efficacy against resistant strains. You all know it very well. Objective of my study was to evaluate the clinical efficacy of tedizolid phosphate in the treatment of mastitis. Let's proceed. However, in our outdoor setting, we have selected patients with mastitis, and these patients were studied with about 100 total 100 cases were selected, and which was given tedizolid and other products So we followed up after 7 days or and 14 days. So we followed it up and we got the results. The result is like the total participant is 100 and the age is below 20 is 10% or 10 persons. Age 21 to 30 is 45 persons. 31 to 40 is 30 persons. More than 40 years is 15%. Complaint was breast pain, like 60% had breast pain. Nipple discharge had 25 persons. 40 persons had breast lump. And fever, there was fever in 20 persons. Redness on overlying skin was in 15 among the 100 patients. Duration of the symptom varies from 5 days to 10 days. 50% was 5 days to CF. 35% was less than 5 days. 15% was 6 to 10 days. More than 15% was 100 days, 10 days. Clinical diagnosis was mastitis in left breast was 25%, right breast 40%, both breasts 35%. Imaging done in all patients. Imaging findings that are like mastitis in right breast in 45, left breast in 30%, both breast in 10%, focal mastitis 25%. Focal mastitis in right is 30%. Focal mastitis in left is 25%. Enlarged lymph node in both axilla 20%. These demographic characters and clinical features of the 100 study participants diagnosed with mastitis. The participants are categorized based on age, with majority 45% falling within the 21 to 30 years of age, followed by 31 to 40 years, which is 30%. Treatment and follow-up. Summary of our study participant was 100 and prescribed antibiotic was Tedizolid phosphate in all patients. Antibiotic course duration 6 days in all patients. Adjuvant treatment was NSAID, PPI, diuretics, vitamins, calcium, and antihistamine methylprednisolone. And follow-up was after 7 days in 60% and 14 days in 40%. It's because our patients are not eager to or compliant to give regular follow-ups, and either they get totally cured within 7 days, so they do not give a second follow-up for 14 days, or otherwise patient are reluctant about their follow-up. That's why 60% only followed up once, and the rest 40% followed up twice after 14 days. Clinical outcome of our study is improvement in 85%, partial improvement in 15%, and no improvement or worsening was 0%. That's a good result in case of mastitis. It summarizes the clinical outcome of the study participants following treatment. A significant majority showed improvement in symptom, while 15% experienced partial improvement. There was no cases of the improvement or worsening of the condition, indicating a generally positive response to the treatment. So you can understand what we are want to share, that we can choose a good antibiotic. We have to choose a good antibiotic because your patient is your client, and your client will not come back to you second time if you fail in the first time. So you have to give a good antibiotic, and then if it works like magic, the magician wins, and otherwise you are lost. No matter what degree you have, no matter how many years of education and skill and knowledge and experience you have, you are failed to the patient. So I don't want to lengthen my presentation today because you are all tired. You have the whole day you have done a lot of clinical duties, but you have to keep in mind that research is part and parcel of our duty, and we can easily gather information from our day-to-day practice. Just keep a notebook, keep a digital platform, or keep a hard copy, and start from now on. I think I have come to an end to the presentation. If you have any question, you can ask. I wanted to add some information that it was actually a challenge for me to introduce or to continue prescribing this product because of its high cost, no matter what. And in case of my study, in favor of my study, uh, I chose one brand only, so that there is no mixing up of results, missing or basing of results. So I mention that, and you might know that which product I choose. Please question.
Thank you, madam, for this presentation. Tedizolid is more better than Tedizolid. And is there any limitation or dose adjustment in renal patient?
Of course, Tedizolid is safer for kidney patients also. But if in case creatinine level is very high, we have to consult with the nephrologist and compare with creatinine clearance rates from introduction to follow-up. But we don't have any such information that it is lethal for kidney, like gentamicin or that kind of product. It has now no study. This study is yet to be done.
Thank you, ma'am.
Thanks a lot. End of the scientific session. Thanks for your patient hearing. Patient hearing. Thank you.